going over the schedule. Monday we have our test. Like I said, most of you guys are done. Mia and Maria will look at their results. It's pretty fast. Tiffany will, if you want, you can come. If not, I can look at your milk and tell you what it is. So for the test, be here on Monday by 11:30. Okay, so be here by 11:30. If we're like a little bit later downstairs or whatever, but I think we will be up here by 11:30. Okay, so that's for Monday. We'll take the test and then we're done for that day. For the Wednesday, where we don't have, by then everybody should be done with unknowns, where you don't have it, again, I will be in this room at 11 o'clock. Come at 11, your habit, come here at 11. We can work on unknown reports, all of that. The biggest issue with unknown report is the dichotomous keys. So try to do the dichotomous key here. Don't even worry about it at home.
Do we need to make one every day or just one big one at the end?
You can do one big one at the end. Some students like to do, like when they did the discussion, they like to start it for every day. So they will go partially there and then the next day they would add it. Like for the first day they would create and then the results for the last day they did. But one complete one at the end is good for me. You can write your report in your notebooks. You can type it. You can have the dichotomous key. If you're not savvy into creating those little things, you can handwrite it and then insert it, take a picture, insert it into your typed up file, things like that. Okay, so that's what we're going to do Wednesday. Again, I'll be here at 11. And then by 11:30, if I see nobody's asking any questions and everybody's here, I'll start lecturing. And then Monday, though, the next Monday before Thanksgiving, we will do lab 13. ELISA is actually a fun lab. Immunoassay is very fast too. No pre-labs for it, but we do need a lab report. So we'll do that one and then we'll come up. And then Wednesday, we won't have a lab, again, same thing. I'll be here at 11. If everybody's here, no questions, we'll lecture, you'll go home, you'll have your Thanksgiving started early. Yes?
Are we going to have homework with the Thanksgiving weekend or not?
I'm not sure. We might on the Sunday, so check Sunday. One other thing I can do is on Wednesday, if everybody is like we're just doing lecture, if you want, I can do that lecture online on Zoom. So for some people who are traveling far, they don't have to come. We'll decide on that Monday. All right, so I can do it. I will be here in the morning for my Bio 300 class, which is local, so they will be here, most of them, hopefully. It's a Wednesday. All right, all of that stuff that I said is in the recording at the beginning. Okie dokie, so let's get started with whatever's left of chapter 13, and then I can do a review for you guys. So what we are left with is immunization. We finished talking about helper T cells. So helper T cells, how they become activated is via the connection to macrophages that are presenting, APCs. They do the double handshake. Their TCR, T cell receptor, has to recognize the antigen that is presented by that cell on MHC2, and CD4 has to confirm that it's MHC2. Then that helper T cell is fully active. It's going to start releasing interleukins for other lymphocytes. It's going to divide, make memory helper T cells and active helper T cells. For the cytotoxic T cells, we said it is a two-step activation. First step is they on their own will find a cell that is infected, that is presenting foreign antigen on MHC1 because it is infected by a virus. Its TCR will recognize the antigen on MHC1. its CD8 will recognize that this is MHC1. That allows the cytotoxic T cell to kind of get tickled, partially active. Partial activation causes the receptors, appearance of receptors on the surface of this cytotoxic T cell. Now, if helper T cell that is responsible for activating cytotoxic T cell is active, it will release cytokines that now the receptors on the cytotoxic T cell can see and attach to. If a cytotoxic T cell is not partially activated, it won't have those receptors. So that helper T cell can produce a ton of it, but that cytotoxic T cell is kind of like blind, doesn't see it when it's partially active. So then those attach and this cytotoxic T cell goes fully active, makes sure that cell is dead, then separates, divides to memory and active cells. B cells, same thing. On their own, they will find an antigen roaming around in the fluids. They will attach to it. The BCR that is attached to an antigen, it will take it in that B cell, process that antigen, present on MHC2, wait for contact by an active helper T cell. Active helper T cell, the same way it connected to macrophage, here it will connect, but this time the purpose is activation of the B cell. So once the connection is confirmed, it will release interleukins and other cytokines that will give the go-ahead to the B cell. That B cell now separates from the active helper T cell, fully active, takes all of its receptors in, divides, produces some memory cells that look alike the naive ones, and plasma cells. Their job is mass production of antibodies. And we looked at the antibodies and everything. So since we have memory, we said we can have immunity. Active immunity, passive immunity. Active means your immune cells got activated and they produce responses that allowed you to have memory cells and some antibodies in your blood. Passive is none of your cells got activated. You have the results of B cells in your system because you were given it from outside source. Immunization is what we do for that. So we're going to look at active immunization, passive, artificial immunity. Active immunization. These are all vaccines. All types of vaccines. We're going to look at four types. Four types of vaccines. They will bring on active immunization.
Are you recording?
Yes. Yes. I doubt myself. So all of them will cause active immunizations. Okay? The difference is, we'll look at them. The difference is some vaccines will force your both B cells and cytotoxic T cells to be active and produce cell-mediated response and antibody-mediated response. Some vaccines, no. All they will elicit or bring on is B cell activation, so antibody-mediated. Whenever if I ask you about vaccines and type of immunity they cause, what I mean is this: which cell type do they activate? Is it just B cells or is it both B cells and cytotoxic T cells? All of them will be the same, active immunity. Okay, a little bit of history, which, you know, I won't ever ask about it, but actually 12th century, China, in China they were working with smallpox. So smallpox is a human disease. Humans are the only reservoir that now has been eradicated from the world, except for some little tiny boxes at the bottom of some sub-zero refrigerators in some countries like US, Russia, and I'm sure in Europe they have it too. They were supposed to, everybody was supposed to destroy everything, but they didn't. But in China, what was happening was smallpox, when it comes, a group of people, there is some strain, it's a viral infection. Some strains cause production of a very small form of the disease. But some types, sometimes it was very strong to the point that the person could, majority of people died from it. We will talk about smallpox because again, it is a danger that sometimes somebody might use it as a weapon, so we will talk about it. In China, what they were doing was whenever they had smallpox coming through, some of the shamans, they were not called shamans, but physicians that they had in every place in China, like they had a village, a person that they went to anytime they had health issues. So they were collecting scabs. It creates poxes and scabs from individuals who had the very mild form. But the practice that they were doing in China, they were adding, some people will volunteer. It wasn't necessary, like it wasn't mandatory, but they would take the scab from that and it had the virus. They will infect individuals with it, so they would hope that they would get the mild one, recover from it, and then they would have immunity. So China was doing this for a long time. And then eventually in the late 16th, 17th centuries, Westerners started traveling to China. And they were seeing it. So a lot of European and British were established. They were in China for a long, long time. So they noticed this. And some of the doctors brought this back to their aristocrats. So they were saying, oh, this is, what they do. So some people thought it was insane. Some others were like, no, I would rather have that. Until Jenner, remember Dr. Jenner, he noticed that, wait, there's something even better than that. And that was the cowpox. So it's the same family virus, but it only affects cows. And humans, it creates a very small, very minor disease, almost like a mild chicken pox, and individuals recover. But what he noticed was milkmaids. Their job was to milk cows, and they were constantly getting it through cracks in their fingers and all of that. If they had cowpox, now they were immune to smallpox. So remember the story that he volunteered the poor gardener's son. So from that, he created it, and because the name of the cowpox was, the cowpox, the virus that caused cowpox was vaccinia. He called what he had created as a vaccine. So that was one of the first vaccines that was produced. From that point on, everybody started thinking, okay, how can I do this? Is there other variations that we can use to bring on immunity? What can we do? And as the technology got better and better, we started forming all these different vaccines. So again, don't worry about any of the dates and all of that, but these are some of the very famous vaccines that we have. In the United States, we're not using all of them. So after hepatitis B, now we have the vaccine for COVID that is new, all of that. So just a little bit of history. As far as the vaccines that we have right now, we accept 4 different types or forms of vaccines. The first one is an attenuated live vaccine. Remember from chapter 11 when we talked about virulence factors? And I said if you remove virulence factors from a pathogen, you make it attenuated. That means the pathogen becomes less and less pathogenic. So by removal of pathogenicity, by removal of virulence factors, you attenuate a microbe, meaning you make it very weak at its pathogenicity. You take its ability to cause the disease away. Many different techniques they have for bacteria, growing it at different temperatures, things like that, conditions, viruses, trying to force them to grow with a different host, things like that. But whatever the big case is, Whatever you do to the microbe to remove its pathogenicity, you have to still make sure that the antigens that our lymphocytes see and recognize remains untouched. Good thing about, so we go through attenuations, removal of virulence. The good thing about that is this. So these are some examples: measles, mumps, rubella, so that's MMR. Polio, the one that the drop one. Chickenpox one, nasal flu. These are all live attenuated. BCG, you guys don't get this here. This is tuberculosis vaccine that the rest of the world gets. The United States doesn't. Typhoid, again, in the United States we don't have it, so we don't get it. So what it does, the thing is this. When you have a bacteria that it doesn't have the pathogenicity and you use that as an artificial form, the good news is you give a small dose to the patient, that bacteria is alive. It still will replicate. So the number is going to increase. Infection happens, but because you're not allowing it, your body reacts to it really fast. So your body responds to that and produces an immune response. Same thing for the virus. The virus, you've taken its virulence away, so it won't cause the disease, but the virus can be an active virus. It can go inside of the cells. It can reproduce inside of the cell and create same low virulence type of virus like itself. Therefore, the immune response that attenuated vaccines bring on is very, very strong. And in majority of cases, it elicits both B cell activity and cytotoxic T cell. Obviously, if it's a bacteria and it's around, doesn't get inside of the cell, in that case, cytotoxic T cell doesn't get activated. But we always say attenuated vaccines have the ability to elicit response from cytotoxic T cells and B cells. So in the case of virus, it will do both.
So on the contact immunity point, if somebody has the, for example, a vaccine of smallpox and is in the encounter with somebody that isn't vaccinated for smallpox, does that mean that they have a chance for them to get sick of smallpox?
Not sick from smallpox, but get the attenuated.
Continuous, right?
Yeah, so they can get immunity, and that's what contact immunity is. And you might have heard of this. So MMR is a live attenuated, and they're viral. So it will elicit B cells and cytotoxic T cells. Individuals who are vaccinated for this, if you have a person who has gone through bone marrow transplant, basically those children are asked by others not to be brought near this person until they get the go-ahead from the doctor that you're okay, you're showing response. Why? Because the virus is in their system, so they can shed it. Measles is a respiratory disease. Even though you see the results on your skin, but the method of transfer is respiratory. So a person who has been who has gotten the MMR, the first few weeks of it, this person is shedding MMR, the attenuated viruses. For a strong person, with a strong immune system, fantastic. I might actually get it, but it has to be very close, right? So you're very close talking. So a child can pass it to an adult who's holding them. You know, they might have some nasal drainage, things like that. But for a person like that, it's very good. They might actually, without getting the vaccine, they can get the products. But they won't get sick because it is attenuated. But for a person who has no immune system, their immune system has been fully compromised because of chemotherapy and they've been destroyed, this person, even a weakest pathogen is dangerous for them because they have no immune system, so it doesn't matter. For women who are trying to get pregnant, they should not get MMR vaccines. If they do, they are supposed to wait about 6 months and then get pregnant. Because rubella, you will see, it will pass the placenta, and it can cause the virus, even the weakest one, can actually cause some neurological damage.
Well, I kind of grew up in this environment where like half of the people thought vaccines are bad because of maybe this factor alone causing the uterus or the baby to
Yeah, there are
sickness
some.
or neurological. Some people believe in this kind of this conspiracy theory that it causes autism
Yeah.
or all that. I don't know whether it's true or not.
No, it's not.
But that's how I grew up. That one, does this mean that specifically MMR?
You could have passed it to the other person. If you were very close, like if you were children and you were constantly playing with one another, so you're in each other's faces, you're sharing food, somebody drops something, you're licking it. I mean, I've seen kids do like weirdest things. One of my son's friends went and licked the door handle, and I was like, they were 4, and I'm looking at it going, explain this to me. Why would you do that? But so that is possible for them to pass it.
Oh.
Without them knowing, they might have some immunity to it and they didn't know. So yeah, it is possible. So contact immunity is actually pretty good for passing it. That's attenuated. Now, there are some bad things about attenuated ones too. Like we said, for a pregnant woman, that attenuated one, fetus does not have any immune system. If it crosses the placenta, it can cause damage in a fetus. For an immunocompromised individual, this is not recommended at all. So this is why, for example, elderly, not even elderly, nowadays they're saying 50 or 60 above, which I don't know, it's not the definition of elderly to me anymore. But nasal flu, they recommend that a person of that age not get it because the nasal flu shots, it's alive and the person can get the flu because they can revert back. Chrissy.
Does this apply to someone who has like sepsis or
Yes.
Okay.
Yes.
So if they're given a vaccine, like,
It
while
should
having
be,
that,
they should double check it with the doctor. So many of the vaccines right now are safe, but for live and all of that, it is highly recommended for a person like that don't get vaccinated. It can actually add to your other issues.
What
So
about like a pneumonia vaccine?
pneumonia, in many cases, they tell them it is not live, it is killed. So for that person, they say take it because it produces immunity and it's their chances of getting pneumonia from real pneumonia is high. But pneumonia is killed in many cases. So it's the dead pathogen. Yeah. So reverting, this is why in United States, we no longer take polio, that is drops. There's 2 types of polio vaccines. One that is a drop, they put 4 drops on the tongue, and that's live and attenuated. And there's the other one that is injection. In United States, we have a ton of money in this country. You can provide and create these vaccines and give it to everyone for free. Since end of 90s, beginning 2000, it was basically totally giving live polio vaccines was totally outlawed. So we only do killed vaccines of polio. Rest of the world, no, they still do that. Why? Because in an area where chances of getting polio is really high, you can actually give that drop to a person and say, take it to your village and put it in the mouth of every child. There is a high chance for that child to get polio without the vaccine. So the risk of it is actually accepted in those cases, all right? Okay, now, inactivated or killed is the second type. In this case, you can actually have 2 forms. Either you take the whole killed pathogen and you inject the person, and in some cases, you don't even, when it's killed, all you need is subunits. The units that have, or parts of this pathogen that only have the antigens on it. So don't even worry about giving the whole thing, just give them the antigen portions of it. Like bacteria, the flagella is what your immune cells react to. So just giving the shots of the flagella is good enough. Those are subunits. Obviously, so these are some examples of what we have. The flu shots that we get, those are killed, inactivated viruses. In this case, because they are killed, the only response that they will bring on is B cells. So antibody-mediated, humoral response. Why? Because if it's a virus, it's totally destroyed and inactivated form, and it remains that way, and it cannot go inside. That's the form of an inactivated virus. That means, or only you've taken the antigens of a virus and you're giving it, it cannot go inside of the cell. So cytotoxic T cells will never get activated with killed. Because of that, they say it's obviously, if you have a viral vaccine that is killed, the type of immunity that it brings on, it's a little bit weaker than the live one, because in this case, cytotoxic T cells don't get activated. So you don't have memory cytotoxic T cells. You will only have memory T cells. They will not produce contact immunity. And then but they have like, so, and then as far as reverting back and all of that and causing issues for immunocompromised, we don't have those problems, but we have other problems. For it to work, so they have to give multiple boosters. And since this, for example, even if it's a bacteria, it cannot replicate, so the dosage that they give, it's bigger. Since you have a higher dose, in the site of injection, that can create some allergic responses. It's more severe inflammation. Some of you guys may notice that when you get a flu shot, and the flu shot has a lot of them, your arm gets swollen and gets very painful. So because your body is seeing so many things, and inflammation over there is more severe. Sometimes when it's subunits, like if they've taken just the antigen of a virus and injecting in that, the antigen might be small, so they attach things that we call adjuvants. Adjuvants are attached to make that antigen look bigger, so your immune system sees it faster. Sometimes that, in some individual, creates allergic reactions. So we can have some severe inflammation at the site of injection. You can have allergic reactions there. And then obviously you could have multiple boosters. With the attenuated one, typically your boosters are like maybe 1 or 2. With the killed, you might have to go and get 4 booster shots to have a child fully vaccinated. Recombinant ones. These are the ones that now we're making more and more of them. These are the ones that COVID was one of them. So for recombinant one, basically, usually what I ask for students to know is now the mRNA ones. So I'll use that for COVID, what it was. So when first of all, this is not a brand new technique. This has been used for 10 years for cancer. So for cancer, it was many people were more prone to accepting this as a possible treatment for cancer. For vaccines, because of controversy over vaccines, they weren't using it as much. With the appearance of COVID and how people were dying, they knew they could make a vaccine for it really fast using this technique. So they started using it, and now it's becoming more and more acceptable. The RSV one that they produce is the same technique as the COVID. So what it is this. They have taken, the COVID is an RNA virus anyway, but what they did is they took the mRNA for the antigen of COVID. And for the first ones, it was the one that was same for all of the strains that was coming out. So they took the mRNA of that one, put it in a protein capsule. So Pfizer and Moderna. They took that mRNA and they put it in a proteinaceous shell. That's the recombinant that they created. The injection that they gave you, that protein shell is basically it's attracted to the cells in the area, attaches to them, it is absorbed, the whole thing is absorbed by the cells in the area and the tissue in the area, and then obviously travels to lymph nodes, and the mRNA is taken inside. Your body, anytime it sees an mRNA, it will translate and make the protein. So that mRNA made the antigen proteins. What does your body cells, what are they programmed to do when an antigen is made inside? Attach it to what? MHC1, take it to the surface. So what they were doing is this. So they created a protein shell with an mRNA in there. Then they give you an injection. So these are your cells. That attaches to the cell and dumps the mRNA there. mRNA gets translated, makes the antigen of that COVID. Your cells are programmed. Anytime you make an antigen, attach it to MHC1, send it to the surface. Now the antigen of COVID is on the surface of your cells, but you are not infected. Because of the injection and all of that, your lymphocytes get to the site. You have inflammation in that site. That was the severe pain and all of that. There is a protein that is not supposed to be in your body, and it's there, and that protein is being absorbed by your cells. So your inflammation is active. We'll call the macrophages and everything. And what is happening, your lymphocytes get there too. So then we produce a full response here. Macrophages try to get some of those protein shells that are there, and then you can produce the B cell and cytotoxic T cell response. So this was Pfizer and Moderna. For JJ, Johnson & Johnson one, instead of putting it in a protein shell, they went and took the capsid of adenoviruses. Adenoviruses are the other type of viruses that elicit cold, like COVID viruses. They target the same group of cells. So they put that mRNA in this one, then you got injected, the same type of cells that COVID got infected. This one, the capsid will go, recognize them, and dump just the mRNA. So again, it was the same. So mRNA is there and you produce it. The arguments that I heard for this was, they are injecting me with mRNA. What if I get mutations? Like, okay, so allow me to explain the process of mutations. So I seriously would set up my whole teaching of you guys how DNA replication happens to many people, and still some of them will not accept my words. Like mRNA cannot join your DNA. There is no mutations. Yes, you can show some reaction to the protein that is being made and this protein shells. You can show allergic reactions, but there is no chance of it for you to have mutations in your body and now suddenly start producing horns. No, we can't do that. Now, your immune system, if it responded to COVID severely, yes, it is possible for your immune system to get the same response that it's producing. Your body is one of those that overreacts to this. So you can have those side effects too. But you will have the same thing if you get COVID. So again, some of these stuff. Never ever would they do this with DNA, because that is problematic. They will always do it with mRNA. There is some like hepatitis B. I have an animation that I'm going to show you guys at the end. For hepatitis B, they again did this with the process and again putting the making sure the antigen gets into the system and we get the hepatitis B. But they didn't use the protein shell, they used recombinant. So they produced it there. Toxoid vaccines. Sometimes for some diseases, you don't even care about the pathogen. The toxin is of an issue. Tetanus is a toxoid. Pertussis diphtheria. Diphtheria, tetanus, you all know. So it produces a toxin that affects your neurons and causes basically contraction of every single little tiny muscle that you have. So ultimately, when it gets to your diaphragm contracts, and that's it. You cannot exhale anymore. When diaphragm relaxes, you exhale. When it contracts, you take a breath in, and that's it. The person basically stops breathing. You can't do anything for them. For diphtheria, there's a toxin that produces a membrane across the throat. So basically, it's like covering your throat and your trachea. So you cannot breathe. You suffocate, right? For those, what they do is, all right, this bacteria, as soon as it gets inside, produces a toxin, and the toxin is of an issue. So they just take the toxin. Again, they neutralize the toxin, making sure the shape of the toxin remains the same, and they give you that neutralized toxin. And they've added to some other particles that makes it look big, so your immune system, again, creates a response and keep producing antibodies. Tetanus is another one of those shots that is extremely painful because they take the toxins, and it's actually tetanus toxin, pertussis, whooping cough toxin, and diphtheroid, so DTaP. They take those, and all three of those, and they add molecules to it so it looks good and big, and your body produces a response. That's why it's very painful. So 4 types of vaccines. Attenuated, live. These are live pathogens that their virulence has been removed. They will elicit both B cell and cytotoxic T cells response. Killed. Killed can be either whole or subunit. These are inactivated pathogens. Whole, the whole pathogen is dead, inactivated, they inject you with it. Subunits, just the parts that will elicit a response. It will only activate B cell. Recombinant one, whenever if I ask you to explain what it is, just say mRNA for the antigens of the pathogen are introduced into the body, and therefore the body makes the antigens eliciting the same response. Recombinant can make, again, B cell and cytotoxic T cells, both of them activated. Toxoid is the toxin that is neutralized and is introduced to the body. Only B cells will produce a response. Let me show you the animation for it. So it talks about it. This one separates whole and the subunit ones from one another and does not talk about toxoids at all, this animation. But it's pretty good. All right, I don't
There are a variety of ways to produce vaccines. Traditionally, vaccines have consisted of killed or inactivated pathogens. A second traditional approach is to use an attenuated strain of the pathogen. During attenuation, the pathogen loses its virulence but retains many of its antigens and is therefore able to elicit an immune response. Subunit or acellular vaccines consist of selective components from the pathogen, such as a surface structure, an internal macromolecule, or the flagellum. Recombinant vaccines are produced by cloning the gene for a structure, such as a surface protein from a pathogen, into a host microorganism. For example, the gene for a surface protein of the hepatitis B virus has been cloned into a yeast cell. The yeast produces the virus surface protein, which can be purified from the growth medium of the yeast and used as a vaccine. Finally, mRNA and DNA vaccines are some of the most recently developed vaccines, with several becoming a critical intervention during the COVID-19 pandemic.
So the recombinant difference between hepatitis B and COVID was this. They used recombinant technology to produce the antigen, then they just give you the antigen. So recombinant technology is happening outside. But as you will see in the COVID, they create a recombinant, kind of a weird mRNA. They send the mRNA. So the production of the antigen is happening inside of your cells. That is what drives some people crazy and it worries them. But honestly, it's mRNA and it doesn't last forever. It is one of the safest. For cancer, what they were using this for is one of the best ways to attack a cancer is for your body to recognize that specific cancer and your own body fighting it. For the rest of your life, you will fight that cancer. So you can use chemotherapy and all of that for breast cancer, for example, fight it off, but there is a very high chance that 5 years down the road, that thing comes back. And when it comes back, it is very hard to get rid of because that means all the things that you did not take this away. It reappeared. But if you put, that's what they are doing for prostate, for some breast cancers, they are injecting, like vaccinating the person, and then they're forcing the immune system to work. It is working for some, for others, they are really trying hard to do this. Okay, so that's the difference. I just wanted to make sure. But both of them are recombinant.
In the case of mRNA vaccines, a piece of messenger RNA from a virus is packaged into a lipid vesicle and administered into the body. This activates the immune system to form a memory of the protein that is coded for by the mRNA. If the virus itself enters the body, that viral protein is quickly recognized and the virus is destroyed by the immune system. For DNA vaccines, the technology is quite similar.
But so far we don't have any DNA ones because you saw what happened with the mRNA. If they do a DNA, it's going to have to be very, very careful because human body actually is designed to ignore DNA and destroy DNA. And otherwise they could have done gene therapy for many of the genetic disorders and it doesn't work. So they have not had any DNA vaccines that I've heard of using this method. So far everything is mRNA. All right, general vaccination benefits. One other big thing that you heard during COVID, herd immunity. Herd immunity basically says this. By the way, vaccines, when they give you that paper on vaccines, to us, they're not giving it that much anymore. But every time, if you have a child, you go to the pediatrician prints a paper and gives it to you, and there's like all the facts about it. One of the biggest things is efficacy of a vaccine. And you heard about that with regards to Moderna, Johnson & Johnson, Pfizer. So they were saying it is 85% versus 93% efficacy. So what that means, it doesn't mean that 93% of the times, like it will take care of 93% of the diseases and 7% it doesn't take. What it is every human being has a different genetic makeup. So even if they get a disease like chickenpox, there is a group of people that are never immune to it, okay? Chickenpox is chickenpox. So that person, their immune system never remembers chickenpox. You can vaccinate this person to death, they will never, ever become immune to chickenpox. Same thing with vaccines. When they say 93%, that means in this large group of people that they tested, 93% of them showed a full, nice response. That we said, you are immune to this. 7% of them, nothing. That's why Johnson & Johnson was actually eventually taken off because it had other issues, but it was not a good vaccine anyway. 50% is not a good thing. Now, herd immunity is when majority of people have immunity to it, especially in the case of a human reservoir disease. So a disease that is elicited only in humans, then in that case, majority of people who are immune, this virus, for example, cannot be in their body and grow, okay? Therefore, the virus loses reservoirs. And when reservoirs disappear, then for those 7% of the population that never had immunity and could not get immunity, now they're protected by us because we are no longer reservoirs. So that was the thing that you were hearing, herd immunity, and then some people were saying don't wear masks. We started pulling back on masks because a lot of people are vaccinated. So let's hope for herd immunity. So now we can make this virus weaker and weaker and weaker, and so we no longer have death associated with it. We still have COVID, but it's not as crazy as it is, and not that many people are getting it. New strains are coming, and that's why they keep staying away, a step ahead. By the way, new strains that are coming, this is an RNA virus. Think back about replication. DNA replication is very inspected at all times. It's very important. So all DNA polymerases edit. All DNA polymerases make sure they do the same thing. mRNA, remember, it's RNA polymerase that is like told, go to this promoter, do everything, fast produce mRNA and go away. So that mRNA polymerase, if it sees an A, it might not put a U in front of it. It might put a C and it's like, never mind. The next RNA polymerase does whatever. So RNA replicates the same way in our cells. That's why it's not edited. It's not checked. So you have more mutations in RNA viruses. DNA viruses, they rarely change. Okay. Flu is an RNA virus. Colds, most of them are RNA viruses. So we see a lot of changes in there. All right. The other big thing is now issues with vaccination. So general vaccination problems that we have. It's expensive. And some countries, this causes socio and economic issues. So they don't have the money to order vaccines, buy vaccines, and they depend on other countries to provide it for them. The other issue, social issues, is this. Some of these poor countries are under civil war already. So fractions grab the vaccine, keep it for themselves, not give it to the others that they're fighting. So there are so many of issues. This is why I always say, from all the fighting that goes over whether or not you want to get vaccinated or not, it's kind of like realizing how spoiled we are in the United States. We don't have to worry about, oh, get me the vaccine. Here we can argue over, I don't want to get the vaccine. The rest of the world doesn't have that problem. The rest of the world, their problem is, somebody get me the vaccine. All right? Inability to produce vaccines for certain infections. So far, hepatitis C, we have not been able to produce a vaccine for it. HIV, Zika, remember the one with the babies with the shrunk heads? We still have not produced a vaccine for it. So some of them we don't have it.
What would be some of the reasons why?
They just can't get it for body to recognize it, to immune systems to see it, or it's dangerous. So for hemorrhagic diseases, dengue, we'll talk about it. Producing a vaccine for it is very dangerous because the second time you get this disease, your immune system goes bonkers and starts causing hemorrhaging all over your body. So it is very difficult. HIV, who you're going to test it on. So again, it's like, ooh, am I going to volunteer to become vaccinated with HIV and suddenly I get the disease? How are you going to test it, whether or not I have immunity? Inject me with HIV, I'm not going to let that happen, right? So, vaccine-associated discouraging issues. This is the MMR that we talked about. I don't know if I talked about it in this class or was it Tuesday, Thursday. MMR, the whole issue with MMR and autism was a doctor in London 1970s, suddenly published a paper and said, when kids get MMR, they all produce autism. When they questioned him about it, absolutely fake research. He had not done a research, nothing in any of his patients. He was a pediatrician. It was his opinion, and he published it with fake results, and basically what ended up happening. He lost his license, all of that. All the research they've done shows no correlation with that, and the only difference is when you get your first MMR shot is the time that the child starts becoming socially active. So that's the only thing, but it was absolutely fake. But still out there, it's in the news, and people who are doing research on autism, this drives them nuts because they can lose funding from people who suddenly believe it either this way or that way, so they don't get it. Mario.
So, for the families that don't want to vaccinate the child, but we just have this situation which some vaccines, like, what was that immunity called, that which when we pass the antigens to the other person?
Contact immunity?
Contact. Is it fine for the families to just not accept and wait for that contact immunity, or is it better for them?
They wouldn't know. A person
You
who,
wouldn't know?
they do know that contact immunity exists. Not that many people have taken this class and know about contact immunity. So they think they might not have it. But the issue is, from what you see, measles came back. Measles is MMR, so measles, mumps, rubella. Measles for the longest time had disappeared. The aspect of questioning MMR vaccine started in late 1970s and started happening in late 80s, and you have packs of population who are doing that. In 90s, measles was kind of coming back, and then in the late 90s and 2000, we have now California, #1 source, Disneyland and all of that. Every summer you have measles outbreak in Disneyland that goes to all the states. Some of these new, younger doctors were like, what is this disease? And the older doctors were like, this is measles. Because they hadn't seen it, so it's coming back. Again, so those are things that you have. General safety issues, actual issues, safety concerns, attenuated one, regressing back, getting virulence. People showing mild reactions to it, like a person who is allergic to egg products. For some of these, like flu shots and all of that, they use eggs to grow the viruses. Genuinely, they can show an anaphylactic shock kind of a reaction. Some individuals, they have certain metal products in the vaccine, and some people cannot metabolize them. Again, for them, it's not good to have that vaccine. Immunocompromised, residual virulence. So those are some of the ones that are there. Okay, passive immunity, the last one. This is, again, your immune system is not doing anything. Passive immunity, the product is referred to as anti-serum, or sometimes you've heard of it as antitoxin. We call it anti-serum because that generalizes. It doesn't have to be against a toxin. It can be against a virus. So, for example, for rabies, this is a disease that has a very long incubation time, but it's a very dangerous disease. So first thing, when a person thinks that they might have been infected, they get an anti-serum, which is a immunoglobulin against the virus, which neutralizes the virus, so the person doesn't get the infection. And then they vaccinate the person. So that's the treatment for rabies. And for a venom of a snake, we call it antitoxin, but generally the best term for it is anti-serum. For a person who has tetanus, again, we give them an anti-serum, but this is immunoglobulins against the toxin of the tetanus. And then we hope that the person doesn't get it, and eventually their body produces an immune response for it. So how do we make anti-serum? So it's pre-made immunoglobulins that we inject into a patient Multiple reasons. This is a very fast progressing disease. This is a very deadly disease. We want to prevent death, and we want to give this person enough time to fight it off. Or the person is immunocompromised, and we want to help them again with the process. So, nowadays, in the old days, they will inject an animal with it, and the animal will produce immunoglobulins, and they will get their blood, extract the immunoglobulins, and inject the person with it. Now we use biotechnology. We call it hybridomas. So this is how we make them.
Mon?
What? What is happening?
Monoclonal antibody.
All right, internet is doing.
Antibodies are one type of antibody.
This is annoying. All right, let's do this again. Is our internet doing something weird here?
It's not on my side.
Huh?
It always does, I notice. Sometimes it goes in and out.
All right, we'll try it one more time. If not, look at it. So basically, the whole thing is this. They will take. So they will take the antigen. All right. So let's say we're doing this for tetanus. They take the toxin of the tetanus. They inject a mammal. Typically, it's mice or rabbit or rats. They inject them. They produce a B cell response. In the B cell response, then they will take the plasma and they will extract the plasmas from their body. Then they're going to come and they can check all these different plasmas and figure out which of the plasma cells are producing the antibodies against the disease that they're looking for. Then they take that B cell, merge it with biotechnology with a cancerous plasma cell. Basically what that does, it creates what they create, they call it a hybridoma. The hybridoma is a recombinant plasma cell that now is mass producing that antibody that you want, the immunoglobulin, and they grow it in big containers. They extract the monoclonal, meaning one disease. So they will take that immunoglobulin, extract it, purify it, and use it as an anti-serum. So they sell it. Okay? So watch the animation at home. And I believe that is it. Okay, let's try it. No? Exactly. All right. I don't know if it's an animation. I'll try it at home and see. Okay, so a little bit of review. Monday, you will have a test covering chapter 11, 12, and 13. 11, very simple. Stick to the, I know I don't have a Word document associated with it, but seriously, stick to the PowerPoint, go through the PowerPoint. Some of them might have more explanation, but if you go through the PowerPoint and you're like, I'm relaxed, I can answer any question with regards to this, you should be okay. The chapter in the book is good. Again, do not use the smart book to study. Use the PowerPoints, the chapter in the book, and your homework. In addition to that, remember we have activities. So in your on your Canvas, you have the activities. So what did I do? On your canvas, you have activities. So chapter 11, the activities that you have. Again, some of these, we were doing this during COVID, so you couldn't just give them a straight this and that. Sometimes we were able to come up with creative questions that had them talking to one another and have ideas. So some of these are like that. But go through them, look at it. So for example, signs and symptoms. Headache. Is it a sign or a symptom? Remember, sign is objective. You see it, you see an object. So it is an objective, you can see it, you can measure it possibly. Symptom is subjective. I cannot see it and I cannot measure it. I depend on the person, the subject, to tell me what is happening. So a headache, is it objective or subjective? Subjective. So it is a symptom. Joint pain, subjective. Fever, objective. You can measure it. Fatigue, subjective. Hypoglycemia, objective. You can measure it and the person will pass out. Right? High cholesterol, objective. It's funny, it's one of those objectives that you might not see it, but you do a blood test, you see it. So it is objective. The patient is saying, I'm fine. What do you mean I have high cholesterol? You're like, well, I'm sorry, but you might have other residual issues. Vomiting, subjective. What about nausea? Vomiting, did you say subjective or objective? Objective. What about nausea? Subjective. So, different. Nausea is you feel like you're throwing up. Vomiting, you are throwing up. So I can see it. Sweating. Objective, but it could be on lowercase. Loss of appetite, again, subjective. So see how you can play with these. And then 5 stages of infectious disease. So I know your book shows 4, but remember your book combines the decline and convalescence together as recovery period. So it's back then the book that we had 5 stages and now it's like 4. So incubation, prodromal, illness, decline, and convalescence. All of them you can talk about. Incubation, no sign and no symptom. Incubation, some symptoms, or prodromal. Sorry, not incubation. So incubation, prodromal, some symptoms. Illness, full-blown signs and symptoms. Decline, lowering signs, possible signs, but also declining symptoms. Convalescence, no signs and no symptoms. So you're looking at those, and then vehicle transmission, vector transmission. Remember, vehicle is inanimate, like dust, water vapors, things like that. Vector is live. Mosquitoes, flies, fleas, ticks. Vector, think of Victor. Okay, Victor is a human being. It's alive. Vehicle is your car. It's not alive. Okay, nosocomial diseases. Diseases brought on in a healthcare facility. 3 types. Exogenous, exogenous, endogenous. Exogenous is they get it from the environment, like they suddenly now have pneumonia because the patient next to them had pneumonia or all of that. Endogenous is when their own normal flora causes a secondary issue like, diarrhea because you've been on antibiotics. Iatrogenic is because a healthcare provider caused it. They used a needle that wasn't clean. So things like that. Site of infection, of surgical infection, those are iatrogenic. So again, use that and your PowerPoints. For 12 and 13, 2 things also. So let me bring these up. These are pretty good. And then also, the immune system. So look at how many pages that thing is. It's 12 pages. So it's pretty good abbreviation, and I kind of organized it the way I lecture about it in class. So it should be good. But again, activities. So chapter 12. Again, it might be something like this because it was pushing them. I'm not going to ask you questions like that. But here, the table, erythrocyte, the other name for it is red blood cells. So I've completed that. Platelets, really, it's platelets. Leukocytes, white blood cells. These are the different types of it you have. You can fill out this and kind of help yourself. PAMS, inflammation, C3A and C5A, cascade end results of it. Interferon. So again, go through these. This might help you with some of that. It's not complete because if I had made a 12 activity for 12, they would have been there for 3 hours in order to finish it. So, but it gives you a pretty good idea of it. And then chapter 13, same thing, antigen. So funny, like some of that comes here, which we talked about in chapter 12. We were going by what the chapter of the book was talking about. Adaptive immunity, memory. So these are pretty good too. Clonal deletion we have. Remember IgG and IgM. I want you to focus more on those. So they're pretty good. And for complement, like I said, that little chart that I had on the side, creating alternate versus that, if you have it, it's pretty good. Okay. All right. Any questions for me?
So cytotoxic T cells, they only target virally infected cells, or can it be bacteria?
No, typically they only do viral because on some rare cases, some bacterial that are intracellular can also trigger it. That like the bacteria goes and replicates inside. That can also cause it to put some of those antigens there. However, the issue with bacteria is this. Why they won't, like intracellular bacterial infections won't always elicit cytotoxic T cell, is because the bacteria is not using the cell to divide. On its own, it's dividing in half. So it is producing its antigens and all of that. And your cell doesn't see or doesn't produce the antigen for it, so it doesn't attach it. In some cases, it might release some chemicals that your cell sees as an antigen and produces it and sends it to MHC1, but it's very rare. So it's typically virally infected and cancerous cells. Because when your cell is replicating like crazy, it can produce an antigen that looks weird. Like the example I use, it's like the Picasso image of your face. All right, but yes, it is mostly viral. Any other questions? I'll try to make it a simple one, but I can't promise anything with regards to the multiple choices. Multiple choices for sciences is weird, and immune system is weird to begin with. It's like this can trigger that, and then shut down this other thing. So it's like a crazy little loop. For my recommendation for immune system, I've told you guys about this before too, where I had a student that created a big giant thing and connected things together for every chapter. Do the same thing. create a giant piece of paper and say, okay, this is inflammation. Inflammation activates this and that. Then inflammation can talk to your innate system or barriers. This is what your barriers do. Maybe even think of it in your own body. What is happening with each of these? Where is happening? Where is my innate barriers? So visualize it inside of on yourself and say, okay, so this is doing this in my body, and I promise you, you will never forget that. And same thing with inflammation. So, okay, I bumped into the door, this is what happened to me. Or when I cut myself and I think I had a redness for a while, I had an infection, like a mosquito bit me. You know, sometimes you get that huge little thing. That's probably an infection and all of that. Go through it.
Do eosinophils, do they also go to the inflammation site? You know,
Yes, they go. And eosinophils, most often under normal conditions, they affect, they want to kill parasitics. They have some phagocytic ability, which I did not tell you guys, and they can produce certain things that destroys parasitic worms. But one interesting thing about eosinophils is that in some cases of inflammation, especially respiratory, they can actually cause asthma and bronchitis. So they typically eosinophil in an autoimmune response, people that are showing autoimmune issues, eosinophils really go high. So
even though they're against.
again, they're not really have a function there, but they're causing problems.
Okay.
So immune system is not always your friend. Sometimes it's causing more issues than the infection.
How much understanding do we need of like the C3, A, B, C?
If you know that chart that you have, you're good. Assume I'm going to make questions from that chart. I know it's crazy, so that's why I always tell my students, if you know this chart, I promise you, you're going to be fine. But honestly, if you know that chart, you have an idea of what is happening there.
When you drew on the board?
Yeah, the one that I had, alternate versus classical.
Okay, thank you.
Okay. All right, guys. So I know Friday's a holiday, but I'm in town. Actually, my husband is going away to visit my son, so my other one always stays in the room. So I have plenty of time. Email me if you have questions. No responsibilities except for the 17-year-old, but still.